this session we'll be talking about the handover to GP format for discharge summaries, which is a new approach to discharge summary structure and content. Let's take a step back for a moment and think about discharge summaries. So you have an admission, a patient comes in, has certain treatment, whether it be planned or unplanned, and they leave, and that point of departure, it's really important to summarise their admission and then hand over to their primary care or their general practitioner for ongoing care, as well as clearly describing what the hospital will be doing at that point as well. So it's a really important point of clinical handover. And so what we've decided to do in this approach is to really focus on the general practitioner as the primary recipient and primary audience of the discharge summary, bearing in mind that there are other audiences to this document, being the patient and their family members are the secondary recipient of the discharge summary, and then the hospital itself and subsequent admissions are also recipients and audience members to this discharge summary document. So we went to general practitioners after deciding that's our primary focus, and that's been something that we replicated from other networks around Australia. And we asked general practitioners what they are wanting and what they don't want, because a lot of discharge summaries at the moment are based on individual units or just individual practitioners' thoughts on what should be in there. There's actually not many networks that describe a clear structure and clear content on what should be in there. So GPs said very clearly they want a very succinct summary. They don't have a lot of time, they just want to distill what went on in a short level but appropriate detail. They want to know the key events and decisions that were made during that admission. They want to know new or changes to the diagnoses or past medical history. They want to know specifically what we're asking general practitioners to follow up on, and they really want to know about medication changes and to be able to have a complete list of medications at discharge and a rationale for why those medications were changed. They don't want all investigations, they just want the key investigations, and we'll break that down a bit later. And they want to know if they need more details, who can they contact specifically within that unit to get the details if they're not in the discharge summary. What they really don't want on the flip side is long summaries that are overly detailed, inconsistent formats that make it hard to find the information they're looking for, incorrect GP details, that's obviously a frustration, delayed distribution, which is obviously a key point indicator for a lot of units and organisations. They don't want excessive investigations. Sometimes there are many more pages of investigations than there are actually of the discharge summary itself. They don't want a lack of detail in medication changes, and they're not particularly interested in patient demographics, which seem to get a lot of focus. So our goal in creating this discharge summary was a clear format, succinct content, specific events being documented, specific medication details and the rationale for those changes, a clear discharge plan, and we want this to be really able to be produced very quickly and distributed in a timely fashion. So that brings us to the handover to GP template, which gives the structure and content. The structure that we went with is the ISPAR or ISPAR format, which is an internationally recognised clinical handover tool, and we've adapted that for use in the discharge summary. So we have the introduction, which is mostly done automatically, the situation being the reason and details about the presentation, the background being their past medical history, the assessment being a summary of the individual issues that were addressed and what we used in terms of management during there, and then their recommendation. And we've broken the recommendation into discharge plans of their destination, discharge, the GP requested follow-up and what the hospital will be doing. And we've also described what we define as key investigations, not too much and not too little, and medications, the changes and rationale with a complete medication list. And I want to really recognise the work of my colleagues Shane, Amy and Michelle, who have done a parallel project that's informed a lot of this space on medication information at discharge, and that project's been a clinical practice improvement project. So let's break it down into the structure. There are some general principles that guide us here. Minimal use of acronyms and minimal use of specialist technology is really key in order for general practitioners, other specialists from different areas, and the patient and family to be able to understand what's in the discharge summary really well. So we were trying to minimise those acronyms as much as possible, just the really common ones, and try and move away from specialist terminology. Sometimes if you're using acronyms and it's going to be saving you time, at least the first time write out fully what it is and then put the acronym in brackets. And we want to ensure the language is non-judgmental towards the patient and their community, and that the patient and family would be easily able to read and understand the content comfortably. That's a really good guiding principle if you're not sure, is this appropriate use of terminology? And in the introduction, this is done automatically. The only thing that's sometimes missing in the electronic medical record is the actual team that was admitted under. So for myself, working in haematology previously, I would always have my discharge summary starting with haematology admission in bold as the title, because it has the hospital and it has the consultant, but for many general practitioners, they're not aware of what the specialty is for that consultant. So explicitly listing it is really important. That automatically happens in OASIS, which is our other system in South Australia. Let's break down the situation. So within situation, we want a one line for their profile. It gives you an idea of their background, a one line for their presenting complaint, and then a succinct paragraph of history presenting complaint. We actually talked a lot about whether the history presenting complaint should feature here versus cutting it out for saving time. But the feedback overall on balance from general practitioners and specialists was they would like to have a history presenting complaint, but one that is very succinct and summarises those events and symptoms leading up to presentation. What we don't want is examination findings. There's an agreement, examination findings do not add a lot here. There's specific situations that you might include that in assessment, particularly when you're talking about a disability and the potential for rehab, documenting the examination or functional findings, put that into assessment. We don't want a list of medications at the time of admission, that doesn't value add, and we don't want the initial investigations. We only want key investigations from the admission itself. Let's move on to background. The background should be a list of the past medical conditions and surgical and mental health of that patient, with ideally a single line of detail, or if it's complex, maybe a short paragraph, a couple of lines of detail there. The assessment is where the details are really about the admission and what went on during that, the treatment, the potential discussions and direction of care. That should all feature in assessment. So we would like to list out the issues individually, obviously starting with the reason they presented or the diagnosis associated with that reason for presentation. We really want some specifics here that we've got from analysing the hospital as well as GP feedback. If you used antibiotics, specify what those antibiotics were and how long they were for. And that's even if you change. So you might say, patient came with pyrexia of unknown origin, initially treated with Tazocin, later changed to whatever it was for a duration in total of this many times. And that's really helpful, particularly when you look back at discharge summaries, to know what they were exposed to in terms of allergies and in terms of what they should be continued on, and if they have a similar presentation in future, replicating antibiotics that worked last time. If there was a change to the direction of care or advanced care planning, particularly if a 7-step pathway was renewed or changed, or if there was a change from more aggressive management to more conservative management, that needs to be detailed there. It doesn't need to be that we summarise the whole family meeting, but a key line that says this is what was changed and who was involved in that consultation and maybe the rationale for, that's a really important part of the assessment. And then lastly, we want to include key consultations with other inpatient teams if they played a significant role in diagnosis and management. So for example, if someone comes in with trauma, it may be that although they were under the trauma surgery team, maybe spinal were consulted because there was a spinal injury, and that might show on an MRI, but if we didn't actually include what the spinal assessment was, or neurosurgery, or infectious diseases, whichever of these consulting teams, if they played an important role in the management and care, summarising what their input was can be really helpful. Now, if you have unit-specific content, so you work specifically for rehab, for example, they would have particular content versus geriatrics may have specific geriatric content that they like to include in discharge summaries that is still helpful for clinical handover to the general practitioner. This is where it includes in there, and that can be prescribed according to the unit. The generic structure says this is where the admission stuff goes. So lastly, the recommendation. We want to specify the discharge destination. This is not always clear. A lot of time this is just going to be simply home. But if it's not, respite, palliative care, hospice, residential care home, down transfer to a different hospital, up transfer to a more acute hospital, whatever it is, that's just where to list it. And then we divide the plans of discharge into outstanding investigations and specifically listing who we're asking to follow that up, who's having the responsibility to chase those results, the plan management by the hospital, and then separately the requested management by the general practitioner. And that's really key that the terminology we're using is not GP to chase, as many GPs will say they're not dogs and they don't like being told to chase things. It's really that respect that comes through in the terminology we use, so requesting the GP to chase up certain things. Now, if you are needing to do that and it's quite either very important or very timely, it's so important we follow up with a phone call and say, I've got a discharge summary on the way, but I wanted to let you know there's this particular result that needs outstanding follow-up. And that's just part of quality handover of care and continuity. And lastly, within recommendation, you want to list who is responsible, whether that's a specifically named individual or if it's a role that changes frequently or has a week on, week off role, specify the role so that if they call switch, they can say, I'd like to talk to the blue hematology RMO, or I'd like to talk to the CCU RMO, or I'd like to talk to the general surgery registrar, whatever it is that need to be easily contactable. The last few things that are outside of the classic ISPAR are the investigations, and we talked about key investigations before. Let's break that down. So if they were imaging or pathology that were critical to a diagnosis, classic one being cancer, you may have cancer of the lung, you'd include the CT chest that helped define that lesion, and you would include the biopsy report that helped with the diagnosis. Those two things are really crucial to diagnosis, we'll include them. If you need to have a comparison of test results following discharge, and where you might be following up, the classic one being a kidney injury, you might put the peak creatinine blood test in and then ask them to chase it up, and then they know what the creatinine and urea comparison is. So that's a comparative change. And what we really want to specify is please do not just tick, tick, tick certain things. I know as an intern, I used to tick the bloods at discharge, or sometimes I'd tick all the bloods at admission. Please don't do that. Just include the key critical results, and that's the strong feedback from general practitioners. They don't want to just have pages and pages of normal bloods that aren't relevant to the patient. When we think about medications, there's two splits. The medication changes, again, the medication name, dose, frequency, and route, and then the reason, rationale, or indication for the change. So be very specific about that. And then medications on discharge is where we want to have a complete list of all of the medications, whether the classic prescribed medications as well as over-the-counter, complementary, intermittent, as required medications, a complete list there. And we hope that with time, our electronic medical record will adapt to that particular format and be easy to do. At the moment, that's included in just a free text. If there's a community pharmacy that's been involved with dose administration aids, and so they're classically Webster packs, blister packs, dosettes, other methods, GPs love to know which of that pharmacy was involved in the discharge planning so that they can continue and have that continuity of care of prescription with that same pharmacy, and that can be a really simple but really important inclusion. So summarising again, we've got the introduction, the situation, which is the reason for presentation, past medical history in the background, assessment where we summarise the events involved in specific details during the admission, the recommendation, which is all about the discharge planning, key investigations being included, and often there'll just be tick box to be included after, doesn't need to be copied and pasted into the text, and then the medications divided into the changes with their rationale and a complete medication list. There's an acronym expansion that's available for this, so you can usually find the most updated version on my EMR profile, or I'll include a link to this below this video. So thanks for listening, and I hope that you'll find the handover to GP structure and content a very helpful one that really encourages quality, consistent discharge summaries for all parties concerned. Thanks for listening.